Well, good evening, everyone. My name is Dr. Leanne Brady, and it's my honor to be here with you this evening talking about advances in composite dentistry. And a great big thank you to GC America for sponsoring this and putting this great program on for everyone. So let's get started and talk about, honestly, what I wanted to share with you is just sort of some of the new things that are going on in the world of composite or adhesive dentistry, and what am I using in my office. So we're going to bounce around a little bit, and one of the first things we're going to start with is this whole conversation about universal dentin adhesives. And what does that mean? What is it about this eighth generation that everyone is so excited about? So one of the things that makes it universal, because we do have to think about how are the manufacturers using that terminology, is the fact that this eighth generation, this universal generation of dentin adhesives, has a very, very unique pH. That pH is because of a very special monomer called MDP, and that pH allows us to choose any one of the four different etching techniques and use the same dentin adhesive. And if you think about prior generations, so 7th, 6th, working backwards, they were very specifically either designed to be used with a total etch technique or to be used without phosphoric acid of any kind in a completely self-etch technique. So one of the things that's great about this new eighth generation is you can have one dentin adhesive, and no matter what procedure you're doing and what etching technique that you may want to use for that particular clinical situation, you don't have to worry about it from an inventory control perspective. This one system will do everything. Kind of a classic example of that for me is one of the few things in my practice today that I still truly total etch, which means that I cover the entire preparation of the tooth with phosphoric acid, and I go 25 to 30 seconds, would be anterior ceramic veneers, where my prep is predominantly in enamel. Most of my other clinical procedures, I'm not going to want to put phosphoric acid on dentin for 25 or 30 seconds, so I wouldn't use a true total etch technique. And I can have one of these universal or eighth generation adhesives in my practice, and I don't have to think about what my assistant put out. I can use it in whatever technique that I want. The other thing that makes this really unique and also has to do with the pH is that the universal adhesives, the eighth generation, are all compatible with dual cure chemistry. So if you're going to put them underneath a dual cure core buildup or a dual cure resin cement, their pH isn't so acidic that it'll interfere with the chemical polymerization cycle of something that you put on top of it. So it's a really unique feature of this eighth generation. And again, thanks to a very special monomer called MDP, we've got all of these features. So not only do they give us the clinical advantages, but they also give us thinking about it from an inventory control perspective. So for some of you, you may be thinking four etching techniques. So let's talk about what they are. So I've already defined total etch. Total etch to me is 35% phosphoric acid, cover the entire prep of the tooth, and let it go for 25 or 30 seconds. When we do that on a preparation that has a high percentage of dentin that's exposed, you are going to risk over etching that dentin. That could increase sensitivity. It actually can decrease initial bond strength. So there's lots of reasons you don't want to do that. An alternative way to use phosphoric acid is a technique that we call selective etching. So selective etching lets us put phosphoric acid on the enamel first. Then we're going to just go to 10 or 15 seconds. Then we're going to finally cover the dentin portion of the tooth preparation. We're only going to leave that phosphoric acid on the dentin a max of 15 seconds. Science today would say 10 seconds is adequate. And then we're going to rinse it and dry it all simultaneously. So selective etching is still a pure phosphoric acid situation, but we're actually using two different amounts of time, one for enamel and then one for dentin, so that we avoid both under etching enamel and over etching dentin. And then the other technique that's sort of in the middle is hybrid etching. So hybrid etching is actually a technique where we're going to use phosphoric acid, and we're going to just put it on the enamel only, and we're going to let it go about 10 seconds on the enamel. Then we're going to rinse and dry. We're never going to put phosphoric acid on the dentin. And then we're going to actually use our universal or our 8th generation dentin adhesive, and it's going to finish etching the enamel. And now it's going to exclusively etch the dentin so that we get the benefits of phosphoric acid on the enamel, and we get the benefits of using something that doesn't include phosphoric acid on the dentin. And then, of course, self-etching is what we all classically have been doing for a lot of years. Zero phosphoric acid in the mix of this clinical situation at all. And the whole etching, both enamel and dentin, is going to be done by the pH of the dentin adhesive. So today, 4 etching techniques, and all of them can be used with a universal adhesive because it's compatible. So the other thing that I want to talk about when we think about this process before we even really get to the composite is a concept called bond degradation. So for decades and decades, what we've been discussing when we think about adhesive dentistry is we've been discussing bond strength. And everybody wants to buy material that has a higher bond strength. So first, if you're going to be thinking about bond strength of a specific adhesive material, understand bond strengths to what? So bond strength to enamel, dentin, ceramic, zirconia, what surface is that particular bond strength you're quoting or someone else is quoting to you, to what surface? But really, one of the things we've come to understand, and it's become a more important conversation in the last decade, is this concept of bond degradation. And whatever your initial bond strength is, all bonds degrade over time. And there's lots and lots of factors that go into the rate of bond degradation. Some of it has to do with the science of the material and the chemistry that's in the bottle. And some of it has to do with clinical scenarios. So bonds that are under really heavy load, like in patients who parafunction, are going to degrade faster. Bonds that are under a heavy load, like we don't want the marginal interface when we do an indirect restoration to be hit by a maximum intercuspal contact, it'll make that bond degrade faster. And then bond degradation to dentin also has to do with literally the biology of what happens inside that tooth. And so one of the things that we've become aware of is something called MMPs, matrix metal proteinases. And it's basically a process that all collagen structures in the human body undergo when they're trying to repair themselves. And so we've prepped the tooth, we've etched the dentin, so we've traumatized that collagen, and that collagen is going to try to repair itself. It's going to produce MMPs. And unfortunately, because it can't repair itself, because we've already done that by placing our adhesive and then our composite restoration, all that the body is doing is actually degrading the bond between the dentin adhesive and the tooth structure, or undoing that hybrid zone or that resin layer. And it actually is just going to cause our restoration to have shorter duration in the oral environment, need to be replaced sooner. So one of the things that's become a standard in my practice today is that every single tooth I prep, whether for direct or indirect, I want to put something on the dentin that minimizes the production of MMPs. So there are 2 chemistries that do that. One is 2% chlorhexidine, like in Conceptus. The other is 3 to 5% glutaraldehyde. And so those 2 chemistries basically are interchangeable. They both are antimicrobial, so they get rid of bacteria in the dental tubules that could cause a pulpitis. They both act as re-wetting agents. So if you have rinsed and dried, you can re-wet the dentin, which will improve your adhesive process. And most importantly, both 2% chlorhexidine and 3 to 5% glutaraldehyde minimize the production of MMPs, thereby slowing the process of bond degradation to dentin. And then if you'd like to, both of those chemistries can be combined with something called HEMA. And the HEMA is actually the desensitizing component. So sometimes these are called prep scrubs, desensitizers, rewetting agents. But just know that the chlorhexidine and the glutaraldehyde are pretty much interchangeable. And it's the addition of HEMA that makes them desensitize. As I say that, just a caveat, you don't want to try to get your chlorhexidine by diluting a mouthwash. The products that are sold as a mouthwash have other ingredients that could actually interfere with your adhesive process. That could actually interrupt your ability to get great initial bond strengths. So you do want to buy a product that's designed to do this, that doesn't have any of those other ingredients. So then I want to talk about some new composite materials, some new composite technology that's come on the market. In order to do that, in order to understand it, I want to back up a little bit and just let's do some very basic biomaterials relative to composite materials. And so everything that's made of composite resin, that's your dent adhesive, that's every composite in your office, that's your sealant, that's most of your, if not all of your resin cements. It's probably the material you're using to make provisionals out of today. I mean, it's amazing to me the percentage of the materials we use in a practice today that are based on composite technology. They all basically have some very similar basic principles. And that one of those is that they are made up of three basic categories of things that go into a composite, right? One is what we call the organic resin, or some people refer to that as the monomer, the liquid, basically. The second big category are the filler particles. And the third category, I'm going to call the chemistry. So chemistry could be coupling agents, it could be photo initiators, it could be chemical initiators. Includes chemistry that slows down photo initiation so that the lights in your operatory don't set it, and only 480 nanometer LED does. They can be coloring agents that change the color of the material. They add chroma and hue. So chemistry. So we've got three big buckets. We've got the resin or the monomer, the filler particles, and then the chemistry. And really, when we think about what are the two big things we're concerned about with our composite materials? One is physical properties, and the other is handling properties. And it's really the interaction of those three buckets that give us the physical properties and the handling properties. And primarily, when we think about the physical properties of a composite and or the handling properties, it's actually the balance between the organic resin and the filler particles that are going to differentiate amongst all of the different resin-based or composite-based materials in your office. So what are the physical properties of a composite that you're concerned about? So tooth wear, we like composite materials that really mimic the exact wear rates of enamel. It doesn't wear faster than the enamel of the tooth around it, so it doesn't basically sink in and the tooth is standing up taller than it is. We also don't want it to be abrasive against the opposing tooth structure so that it wears down the opposing tooth. So we want really similar wear abrasiveness patterns as real tooth structure. Water absorption, anything that we put into the oral environment, we don't want it to absorb moisture and swell or change shape. We also don't want it to be water soluble. We want it to be really resilient in a moist environment. Shrinkage stress, we're going to talk about that a little bit later in the webinar. Some of you may be thinking about the terminology polymerization shrinkage. Today, sort of the modern iteration of that is shrinkage stress, and we'll talk about why we change that. Flexural strength, or the elastic modulus of a material. We actually like materials to sort of have a similar elastic modulus to real tooth structure, so they can bend and flex and move with the tooth, which means that we're not putting stress on the adhesive interface, and therefore we're not causing that adhesive interface to degrade or break down, or so the restoration falls out. And then fracture toughness. Obviously, we want materials that don't fracture, right? So lots of great physical properties of composites that are important to us. From a handling property perspective, probably the most important handling property of a composite material is its viscosity. And so for certain clinical usages, we like one that's lower viscosity. For certain clinical things, you may want that's higher viscosity. And certainly it can't be so runny that it's not usable, and it can't be so dense that it's not usable. And then I'll also add polishability as a handling property that may be important to you. You could put that in physical properties. And then also thinking about that material from a standpoint of, we call it sculptability, but again, it goes to viscosity. So how the material is going to be able to be moved by you with instruments or delivery systems in the mouth. Okay. So there's a really basic relationship in composite technology between the resin or the monomer and the filler that tells us basically about the physical properties and the handling properties. So as you decrease the filler content, so the filler content decreases, so the material is a much higher proportion of resin or monomer, pretty much all of the physical properties get worse, less desirable. So water absorption increases, shrinkage increases, flexural strength decreases, fracture toughness decreases, so it becomes more fracture prone. And the only thing that really improves about a material as we reduce the filler content is the viscosity. So the material becomes more and more liquid or more and more flowable, the less filler that we put in it as a general rule. The opposite is also true. Over the years, the more filler content we can put into the resin or the monomer, the higher the filler content percentage, all the physical properties of the material get better. Its water absorption decreases, its shrinkage decreases, which creates less stress on the adhesive interface. Its flexural strength increases, its ability to flex or bend increases. Its fracture toughness, or its ability to resist fracturing or breaking, increases. And classically through the years, the negative to that has been that the viscosity increases. And so this has basically been the battle of probably 30 to 40 years of composite research and science, right? How do we continue to increase the filler content percentage of our composite-based materials without sacrificing handling properties, without making a material so viscous, so dense that we can't use it, it becomes dry, crumbly, we can't deliver it into the cavity preparation. It's just unworkable. This has been honestly the biggest place we've seen evolutions of dentistry. And if you've been practicing, you'll know that we did that by working on the filler and changing the filler. So we went from macro-sized particles to micro-sized particles, and from micro-sized particles to nano-sized particles, because one of the things we learned is the smaller you make the filler particles, then the more of it you can put into the resin matrix, the monomer, without having a viscosity problem. The material becomes too viscous. So basically, generally, up until a couple of years ago, I would have told you that you could use a very, very basic rule of thumb. And that basic rule of thumb was that the more liquidy the composite, the lower the filler percentage. And the denser or firmer the composite, the higher the filler percentage. So literally, you could put composites out on a mixing pad in your office, and you could have made some very general rule of thumb decisions about the physical properties of those materials, and therefore what they were appropriate for clinically versus not being appropriate for from a clinical perspective. Okay. And you know that this general rule of thumb about viscosity kind of held true until a couple of years ago. And now we can't really say that rule of thumb anymore. And kind of what shifted this from a perspective of how we were dealing with this in our offices, first, truthfully, was transitions in flowable materials. And I can think back enough decades that I can remember when pretty much every flowable on the market was unfilled or had such a low filler percentage that it had very, very limited usage in a clinical technique perspective. So, we might use it almost as a liner underneath a direct composite. Obviously, those types of flowables could be used to repair the bubbles, the porosities that show up in your bisacryl provisionals. It had very limited usage. And then what we started to do is the manufacturers started to increase the filler percentage even in all of our materials that we called flowable. And so even in the group of flowable, you had very low viscosity flowables that had low to no filler. And then you had what we called high filler percentage flowables, which did still flow, but they had higher viscosity. And you could still basically tell the filler percentage by the viscosity. So if you put them out on a mixing pad, and as you're injecting it, it's just becoming sort of this big flat lake. Very low to no filler percentage. If you could actually inject it out and you could almost shape it like a soft serve ice cream cone, and the slower it slumped, the higher the filler percentage was. So you could still use that as a general rule of thumb. And all those different filler percentage flowables, it was still flowable, and it still basically all had the same clinical indications. None of those materials had wear rates that allowed them to be the surface layer in on a functional surface of a tooth. So occlusal table in a class 1 or class 2, lingual in a class 3 or class 4. They just didn't have the physical properties because the filler percentage was not high enough that we would cross that threshold, right? And so even in the world of high filler percentage flowables, we were still using them in really low stress areas, non-occlusal or functional areas, kind of as a liner underneath other composites. Some of you may have used them in something called the snow plow technique, where you would put flowable in a class 2 box, leave it uncured, then pack material on top of it to try to get it to seal your margins. There were really no indications to use a true flowable material as a standalone restorative material, because again, the filler percentage was too low, therefore the physical properties were not good enough. Well, a couple of years ago, the whole world of composite resins kind of got stood on its head, thanks to a new material that GC America brought to the market. And the name, as you'll notice, isn't flowable. The name is injectable. And I'm always really particular about this, and I'm assuming that GC probably was also in the name to try to differentiate it, and I do hear dentists all the time talking about this material as a flowable. And I just want to really caution everybody. The reason we talk about it that way is the delivery system is similar. It's a syringe, you put a tip on it and you inject it out. But it is totally different from the clinical indications that you can use this material for, okay? Which is why really we're going to call it an injectable composite, okay? Because it is a standalone restorative material. You can use this material for the functional surfaces, so occlusal surfaces in a class 1 or class 2, lingual surfaces in a class 3 or a class 4. You do not have to put anything else into the cavity preparation other than this material. And that's true because it has an equally high filler percentage as all of the composite materials you're accustomed to using, that you have to put a little compule in a composite gun, or that come in a syringe and you deliver to the cavity preparation on the end of a plastic instrument. So how did GC do this? How did they figure out how to sort of conquer the viscosity barrier and create a material that has an injectable viscosity and yet has a high enough filler percentage that it has all of the same physical properties as all of the other sort of nano fill composites that are out there on the market today? Well, they did it basically in two ways. One was an adaptation of what we already knew. The smaller the filler particles, the more of them you can put in without adversely changing the viscosity. Nano-sized particles is a really big category. Like, it's going to be really hard for somebody to get filler particles that are smaller than nano. I don't even really know what's smaller than nano. If we have somebody who knows physics better than I do on the webinar, you might know that. But nano is such a huge category that it's going to be harder to get out of that category, but they made their particles even smaller than any other nanofill or nano hybrid composite that's on the market that it competes with. And then they actually did something that was really unique. And what they did was they actually take those filler particles and they actually coat those filler particles so that it reduces surface tension. We're all kind of familiar with that. That's exactly why we put silane on the inside of a ceramic restoration before we bond it in to reduce the surface tension, or you might be using like an MDP product on the inside of your ceramics. All of that is designed to reduce surface tension. And when you basically coat all of the filler particles prior to putting them in the organic matrix with a chemistry that reduces surface tension, not only do you have smaller particles, so you can put the same percentage as a denser material and it maintains a lower viscosity, but those particles can now slide past each other more easily, and therefore you don't get that increase in viscosity. So now you have an injectable composite material that has the things we love about that delivery system, about the fact that it's injectable, and you've got all of the same physical properties as all of the other materials that up until now we've had to pack, condense, or sculpt, so that we have that ability, that versatility in this delivery system. So why do we want something that's injectable? You know, why do we try to use lower viscosity materials? And so a good piece of that has to do with, especially in like class 1 and class 2s, not incorporating air bubbles. And so if you've ever taken a bite wing of a class 1 or class 2 composite you've done, and it kind of looks like Swiss cheese, you can kind of see all of the air or the porosities. We introduce that because we're basically taking a very dense material and we're trying to pack it or condense it into that cavity preparation. Sometimes we actually trap air under the composite between the bolus of composite and the prep. Other times we introduce the composite as we try to condense with a phenomenon called suck back that has to do with how our instruments are sticking to the material. And every time we lift the instrument in and out of the cavity to move it and condense another area, we're lifting some of the composite underneath, right? And so trying to get really dense fills without any air bubbles is much easier with a more flowable material, okay? And these materials also get way better adherence to the walls of the cavity preparation. So you get way better marginal integrity, okay? So there's lots of advantages to something that basically is less viscous that you can inject, right? And so these materials are really beautiful and gorgeous. They're easy to deliver. And one of the things, again, you'll have to, if you've not ever used them, I would encourage you do it. Because if you're concerned that because they're lower viscosity, they're going to slump or you're going to have trouble having it hold its shape, that's not true. The viscosity is really right at that perfect place where it's low enough viscosity that you can inject it into the cavity preparation. But wherever you put it and whatever shape you make it, it's going to hold that shape. I mean, it would slump eventually, but obviously I can't slow down enough to make that happen. And I can actually move the material around if I want to with an Explorer. So it's a really phenomenal material and gorgeous material. So I will tell you the place that I started using it in my clinical practice was in class 5s. Class 5s can really be a conundrum in the world of composite dentistry. We're putting a restoration at the part of the tooth, the neck of the tooth, where we get the most flexural stress as the tooth is being loaded and in excursive movements. And so, you know, lots of people try to do these with glass ionomer because glass ionomer has a very similar elastic modulus to natural tooth structure. So they tend not to pop out or debond the way composites will. Okay, but glass ionomers aren't as pretty as true composite materials are, and even resin modified. Sometimes we want the aesthetics of an actual composite resin. So given the great physical properties of this material, I was like, I'm going to try this on my class fives, and I've not gone back. I use it for that pretty much exclusively. I also use it really often for my class threes, my class fours, incisal edge repairs. So, that if you've not used it, I would encourage you to try it. And it can be used kind of any place that you want to do a direct composite, occlusal in the posterior. There's no limitations to the different, class one, class two, class three, class four, class five, class six types of cavity preparations. It's indicated for all of those. And the uniqueness of the delivery system and the viscosity of the material is going to help you figure out where it has most clinical benefit in your practice. So I encourage you to do that. So this is a whole new category of materials, this new injectable category of materials. They do make it in a traditional cure. So you're going to do it in 1 to 2 millimeter increments. And they also make this material in a bulk fill. And that really is sort of the next kind of advance in composite that I want to talk about is just bulk fills in general. And this will apply to both the genial injectable bulk fill, but it'll also apply to other bulk fills on the market. I have to tell you, when bulk fill composites first came out, I was kind of like, are you kidding me? You've just spent 20 years telling me not to bulk fill, that I need thinner and thinner layers and wave cure and angled layers and all of this kind of stuff so we could overcome C factor. So when they first started to say, okay, we could bulk fill, I was probably one of the biggest skeptics. And so I had to go to the science. Tell me how we did this. Like, how did we come up with materials that all of a sudden now we can do 4 to 6 millimeters for depth of cure, and we're not going to have big challenges. Now, there's lots of different kinds of bulk fills on the market. There are 3 kinds, basically. There are injectable, like genial injectable bulk fill. There are condensable bulk fill materials, and both of those two do not require a cap layer because they have the physical properties. They can be in occlusal function. And then we have the true flowable bulk fills that all require a cap layer, again, because the filler percentage is low enough that the physical properties and the wear resistant isn't high enough. So you have to put a traditional composite with a higher filler percentage over the top of it, right? So it's multiple different delivery systems. But how did the manufacturers even come up with bulk fill? So this goes to the conversation I started earlier between polymerization shrinkage and this sort of new term, shrinkage stress. And so, originally when we thought about how composite shrunk, you would know that if you put a bolus of composite into a cavity preparation and then you light cure it, as it polymerizes, it shrinks, and it would shrink to the center of the bolus of that composite. So if you think about a class 1 cavity preparation and you put composite in it, the center of the bolus of composite is in the center of the cavity preparation, away from all the walls. And as it polymerizes, it's shrinking toward its own middle, and it's pulling away from the margins. All of that shrinkage stress is accumulating at the margins and basically would cause those margins to leak prematurely, break down prematurely, get secondary decay. So we would manage the way we would fill a cavity to move basically the center of the bolus of composite so that the polymerization shrinkage wasn't jeopardizing the bond. So in order for us to be able to come up with bulk fill composites, the manufacturers actually had to figure out how to control the direction of the shrinkage and not have all of the shrinkage be pulling toward the center of the bolus of composite. They call it directional shrinkage. And so I don't know how they figured this out, but they figured it out. And so they've actually managed, because they can They can control the direction in which the polymerization shrinkage is occurring, and it doesn't all occur in one direction, it's multi-directional. And therefore, the stress that's accumulating on the marginal interface actually decreases to the point where it's no longer a concern to actually polymerize a bolus that's 4, 5, 6 millimeters thick, and you're not going to have to worry about it degrading that bond. The other thing they had to figure out is how are we going to get light all the way through a 4 to 6 millimeter bolus of composite? They did that in two ways. One, they increased the translucency of the composite. So across the board, most bulk fill composites tend to look more translucent. They don't quite have the same aesthetic opacity light reflection as regular composites. And then the other way they did that is that they actually changed out some of the photo initiators. So they actually make the photo initiators more powerful. They don't put quite as many things in that retard photo initiation so that you can get greater depth of cure. Okay. So between managing the direction of the shrinkage, polymerization shrinkage, so that we reduce stress on the bonded interface, increasing the translucency, changing out photo initiators, we actually came up with bulk fill composites that actually some of them have better physical properties than some of the non-bulk fill composites. And again, you get to choose the kind that can be standalone restorative materials versus the kind that need to have a cap layer on top of them. So a couple other things, we're going to actually leave sort of biomaterials for a second. Let's talk a little bit about matrix systems. And I wish what I was going to do is I was going to show you some super breakthrough, change your life matrix system that you only ever need one ever again. There's no such thing. And the reason, I know matrices is a challenge is because we keep inventing new ones. But let's just go through some basics and maybe some tips in our time together. One is pre-wedging. So pre-wedging is when you actually insert the wedge before you prep the tooth. So you give anesthetic, once the person's numb, put the wedge in. And this is a technique I did in dental school and then I stopped doing because it felt like something they just made you do in dental school. And I started again about 15 years ago, and that's the only way I do class 2 restorations. Why does pre-wedging work? One of the two jobs of the wedge is to actually push the tooth, compress the periodontal ligament on the other side of the tooth, separate the tooth enough of a distance to overcome the thickness of the matrix band. And the scientific research will show you that the wedge has to be in place 3 to 5 minutes to get really good separation. And putting it in after you've prepped isn't enough time before you actually start to place composite in a class 2 box. So I actually took this photograph, these two teeth snapped to floss. I placed the wedge. This photograph was taken exactly at 3 minutes. And now you can just see that tiny little air gap between the two teeth. So if you want predictably tight contacts every single time you do a class 2, my answer is put the wedge in before you ever prep the tooth, and you will have unbelievably tight contacts. And what kind of wedge? Truthfully, today I would tell you anything other than a wooden wedge, because you don't want to pre-wedge with a wooden wedge, because if you prep it, then little splinters occur. But if you happen to have a favorite kind of a wedge, other than the wooden kind, you can certainly use them. The clear wedges are there designed to transmit light. So a clear wedge only works if you're using a plastic clear cure through band. They have no advantage with a metal matrix band, but lots and lots of different systems out there for wedging. How about the bands? I actually will tell you, I use a traditional stainless steel sectional matrix in the posterior. I don't use the cure through kind. I like the ability of the metal band to create the interproximal tooth shape. And I can actually bounce the light off of the stainless steel band. It refracts back into the box. And so you'll get greater depth of cure in a class 2 box if you're using a traditional band versus these clear bands, which truthfully, if you think about it, that you're not putting your light anywhere where it needs to go through this band. So that, of course, is a challenge. So you don't need these clear bands in the posterior. Let's talk really quickly too about side-by-side class 2 preps. I know that's everyone's favorite. And you can't do it with one band because one band basically gaps into the other prep, and you get a weird interproximal shape that you have to trim with a handpiece before you fill the other. You can't do two bands and load both preps because you'll have an open contact. You can't wedge enough to overcome two band thicknesses. So for years and years and years, I was doing two bands side by side, fill one prep, take everything apart, then put a new band, another wedge, and another ring, and fill the second one. Okay. And today I'm going to show you a video of how I use Teflon tape to fix that. I also use Teflon tape for something like you see in this photograph, where the band is gapping away from the prep a little bit. I will not take everything apart. I don't shove another wedge in there. I literally just very delicately condense a little Teflon tape on the outside of the band right there with like a perio probe until I push the band up against my class 2 box. Okay. So honestly, other than pre-wedging, my tip today for how to get better fits and better adaptation of your matrix band systems is add a little Teflon tape to the system. Okay. So I do want to go ahead and show you this video. I'm going to hope that it's streaming okay over the internet. But here's one band, two boxes, and you can see how the band gaps into the adjacent box. So how I do this in my practice today is I take Teflon tape and I actually put it in the prep that I'm not going to fill right now. Okay. And I'm going to actually condense it in. So you're going to see, I'm going to actually pick up a condenser and I'm actually going to condense it. And that's one of the things about Teflon tape. It sticks to itself and you can condense it and you can actually make it pretty firm. Okay. And firm enough that I can actually then load my composite in the other prep against that band and the band won't move. And so once I've got it condensed pretty well, I'm going to actually put my ring back on. When we're doing a quadrant of composites, we always fill from posterior toward anterior. Fill the most distal prep first, and then move to the mesial so that any hemorrhage or bleeding or trauma is draining away from the preps you're filling and not running over them. Okay. But look at how beautiful that band adaptation was because of the addition of adding just the Teflon tape. So if that's something that you've not tried, play with a little Teflon tape. It will really kind of transform how your matrix band systems work. Composite warming is definitely not new, but it's definitely becoming way more popular again. What does adding thermal energy do to composite? It actually increases the flow. It doesn't change the filler percentage, but temporarily, while it's warm, the material gets less viscous and it flows. And we've talked a lot about the advantages of a less viscous material. When a material is less viscous and it flows better, just like when we talked about genial injectable, you're going to decrease cure time, you're going to decrease micro leakage because you increase adaptation to the walls and the margins. You can also increase depth of cure. Okay. I keep composite warmers in every one of my operatories. And so when I am going to use my sculptable or my condensable composites in a specific clinical situation, it's been in a composite warmer. And therefore, I've got some sort of temporary ability to have lower viscosity without actually changing the physical properties of the composite. So placing composite, one of the kind of the advances over the last couple of years has been composite instruments that have disposable tips. And those tips are not only disposable, which means that you don't have to sterilize them, autoclave them. You autoclave the handle, but the tips get thrown in the trash. But the tips are made of a material that's non-stick. So we don't have to worry about that stickiness or the tackiness. And we're not, having to think about the really expensive gold instruments or the anodized steel instruments. So lots of different instruments like this. This happens to be one called C, Shape It, capital letter C, Shape It, which is a silicone tip. which I love for class 2 or class 1 composites in the posterior. And then there's lots of instrument companies now that make these handles with a whole variety of sizes and shapes of tips for composites. And again, you put the tip on there that you like, you use it, and then you throw it away. So only the handle gets sterilized. So they have them for anterior and they have them for posterior. So really, when you think about this, we've talked about some advances in dent adhesives and covering the new 8th generation or universal adhesives. 2 advances in composite materials, the injectable materials from GC America and bulk fill materials in general. Some tips and tricks, because there really aren't any new advances in matrix band systems that I'm aware of that'll solve all of your questions. But definitely some new advances in instruments that we can place with. So there's always new stuff coming out from a standpoint of in the world of composite dentistry. And then I'm just going to close with kind of 2 of my favorite tricks. And these are instruments for finishing. One is called a Montana jack. That's that hygiene instrument. This is the most incredible, sharp, durable, nearly unbreakable hygiene instrument. And if I do get a little bit of flash around a class 2 box or past a margin, this is my favorite way of removing it versus with a hand piece. The other device on this slide is called a quick strip, QWIK, and it's a smooth metal band with just serrations at the edge that can be really, really phenomenal for opening a contact or going back through a contact. And so both of these are pretty much standard fare in my setup, in my operatory, my kits, and in our setup when we're doing any kind of adhesive or composite-based dentistry. So we have had a couple of questions come in. So we've got just a little bit of time left. So I will answer some questions. And if you have any more, just pop them in the Q&A. Okay. I think the first question I think I answered, but it was, what is the difference between the Genial Universal and the bulk fill? And it's depth of cure. So the Genial injectable that isn't bulk fill has a standard 1 to 2 millimeter depth of cure. The Genial injectable, that's the bulk fill. You can actually go to 4 millimeters. And because it is a bulk fill, it is going to be slightly more translucent. You're not going to have the same optics or aesthetics as in the regular Genial injectable. Right. Next question is, do you use the Genial composite in your class 2 restorations? I'm going to assume you mean the Genial injectable. And absolutely, you can use the Genial injectable in a class 1 or a class 2. You can go all the way from the base of the prep all the way up to the occlusal table. Now, if you were doing that, because it is a lower viscosity material, you're not going to need to condense it. So you're not going to need any condensers. You're just going to load. But you are going to need different tools for creating your occlusal anatomy. Classically for me, after I inject in the Genial injectable, I actually will use an Explorer, and I just start to move the material around gently with an Explorer. But it's just a very different technique as far as how you're going to shape your anatomy with the injectable material. All right, so next question is, I've had contacts that are so tight they break floss. What do you do if a contact is too tight? I just showed you quick strip, QWIK strip. That's my favorite thing to do. I've rarely, if ever, have a contact that's so tight that I have to loosen it again. And a lot of the times with those pre-wedging and contacts that are tight, I just run the quick strip through there once, and then I can go right back with floss, and it works pretty perfectly. Okay. Next question is about Teflon tape. And it says, good technique, good to know. Where do you buy Teflon tape? In Home Depot? Yes, you can buy Teflon tape or plumber's tape at Home Depot or Lowe's or on Amazon. Just remember that's not sterile. If you do that, and I will do that, my assistants cut it up into little 1.5 or 2-inch strips. We put them into autoclave bags and we run them through the autoclave. Don't autoclave the plastic holder that it comes in. You got to cut it up. And you can also buy plumber's tape that's specifically designed and sold for dentists. But either way, lots of ways to get Teflon tape. Next question is, how long do you warm the composites or leave it in the warmer? And so, most of these composite warmers actually have sort of a rapid setting. And so you can put it in, you can press the button, it'll be warm enough to use fairly quickly. Okay. For us, we actually, if I'm going to use my composite warmer, we'll actually load the composite into the warmer at the beginning of the preparation, so that it's been sitting in there usually 5-10 minutes. One trick I will tell you is don't leave composite compules or syringes in a composite warmer day after day after day and leave it turned on all day long. You will eventually evaporate off the monomer and the composite will become unusable. So if you do lots of composites and you use your warmer all the time, your assistant might load it first thing in the morning, turn it on, leave it on all day, and then turn it off at the end of the day. But any composite you haven't used, you're not going to want to warm day after day after day. So that's why we do it where my assistant will literally put the composite in the warmer right as we start that particular patient. By the time I need it, it's definitely warm enough, no question. Okay. Another question came up. Do I rinse after I apply Gluma? I actually don't. So I want to be really clear. The manufacturer's directions for Gluma specifically is to apply it, scrub for 60 seconds, rinse, then do a second 60-second application, and then rinse it again. I do not do it that way. I actually apply my Gluma to the tooth. I just lightly sort of scrub it into the dentin, and then I lightly air dry and I leave it behind. I do it that way. That's the way it was done in a study that actually looked at the impact of glutaraldehyde and HEMA on bond strengths, which, by the way, it has no impact. It does not increase initial bond strengths and it doesn't decrease initial bond strengths, no matter what the adhesive. But the way they did it in that study is just to apply it and leave it behind. So that's how I do it. But as a caveat, I want to be clear that is not the manufacturer's directions. Next question is, how long have injectables been in use? And you know what? I'm not going to give you a precise answer to that because I will mess it up. They have been around multiple years. And the truth of it is, I lose track of whether they came out. I want to say they came out before the COVID shutdown, which I know is how everybody tells time these days. But they've been on the market a number of years. I just can't swear to exactly how long. Okay. Next question. Once you are done filling the adjacent composite cavity and remove the matrix wedge and then remove the Teflon, doesn't the gingiva bleed? How do you handle such a situation? So as long as I haven't prepped the tissue, okay, any bleeding I'm going to get is going to stop again as soon as I insert the wedge again. And so if I've got really great adaptation of my matrix on that first prep I fill, and I do not have to feel the need to go in with a hand piece and a mosquito diamond and trim the gingival margin prior to filling the second one, I'm not worried. Even if I see a little bit of bleeding, as soon as I place my matrix band and the wedge back in, it's going to actually act to compress that tissue and the bleeding will stop. Okay. If I actually do have to trim it, so I've got a little bit of flash, I got to trim it before I fill the other box. I potentially nick the gum tissue a little bit and I've got that kind of bleeding. Then for me, I'm going to use retraction paste. So pretty much all retraction pastes across all the manufacturers have the same active ingredients. They are really, really great hemostatic agents. They don't stain the tissue. They don't stain the dentin of the prep. You got to leave them in place for 60 seconds, solidly 60 seconds to get great hemostasis. So if you need to put a little bit of retraction paste on that tissue, set a timer for 60 seconds, rinse it and dry it. Promise it'll not be bleeding anymore. Now put your matrix band, put your wedge, put your ring, and fill the other box. Okay. Last question is, what is the curing time for the injectable? You're going to do, 10 to 20 seconds per increment. If you're doing the traditional genial injectable, an increment is going to be 1 to 2 millimeters max. If you're doing the bulk fill, you can go to 4 millimeters. And classically 10 to 20 seconds depends. I'm vacillating because I don't know what kind of light you use and how many milliwatts of energy your light is putting out per second. But what I also will tell you is there's no such thing as over curing. So I will tell you, I probably could do 10 seconds in increment in my practice, but I do 20 because there's no such thing as over curing. So a few more questions kind of popped in here. You shared the pros for injectables, but are there any cons? The only con, and I don't know that I would put it in my con box, but it's a different viscosity material. So as I said, if you're going to use it in a class 1 or class 2, you're going to need to develop a different technique for how you do your occlusal anatomy. So you can overfill and then trim back with a handpiece, or you can try to perfectly fill and then sculpt with an explorer, which is honestly what I've started to do. But I will tell you, there was a little bit of a learning curve for me when I first did that, because I was used to a material that you could condense and then you could sculpt with like a beaver tail burnisher. You can't do that with the injectable material. But in exchange for it, you can get this just gorgeous, beautiful marginal integrity because I can tease it up over my margins with my Explorer. So that's the only thing I would tell you is that's why I said I started with class 5s, fell in love with it for class 5s. Then I started using it for class 4s in the anterior, which it's gorgeous for, incisal edge repairs. So I just expanded. I started small, and then the more I used it, the more different things I asked my assistant to pull it out for. Does injectable lead to air bubbles? If so, how do I prevent it? So great question. And the answer is no, as long as you are using the tips from GC America for their injectable. This is something you have to really drum into your chairside assistants. And you've got to keep them separate because they look just like the other flowable tips with the black hub. So if you take a different tip for an actual traditional flowable and you put it on the injectable tube, you're going to get air bubbles. Their tips that are made for the injectable actually have a way they vent air, and you do not get air bubbles. It's awesome. But if you don't buy their tips and use their tips, you're going to struggle with that. So thanks for asking, because that's a really great question. All right, that is the end of all of our clinical questions. So I am just going to finish by saying thank you again to everyone. Thank you to Viva Learning for inviting me. It's always an honor. I always appreciate being able to participate. Thank you for GC America for the invite. And I hope everyone has something they can take back to their practice tomorrow that will help make the next composite you do a little easier, a little more predictable, a little greater longevity, and have a great evening, everyone.